Some of you might know me, some of you wouldn't know me. But I have been quietly teaching a substantial number of doctors to pass the exam. Most of my students are currently working in Australia on limited registration because they know me through hospitals. So they've all been here for a while and they want to pass the exam. So I've been teaching them and I have a success rate about 98%. And it involves not because I am a good teacher. I'm fortunate enough to get good students. And some of you would know Rajni. So from the time I taught to now, I've had this joke with everybody that you must score more than me. I got 12 out of 14. And it was the joke. So usually all of them would call and tell me that, okay, I didn't beat your record. So Rajni is the first one to beat my record. And it is incredible because it shows. I know you don't want me to say it, but getting 13 stations is a lot of work. A lot. I was there with your journey, so I know how much you worked for it, your dedication. And it is hard when you're a mom of young bubs. It is really, really hard. And we've all been there. We've all gone through this journey. And as a mom and as a fellow doctor, I'm incredibly proud of the journey that you did because giving up is already hard. No feedback already done. No, I just started, doctor. So it's often when you start. I remember her first few sessions. She was so lost, and she was more worried than anything else that she's going to tank all the cases. And I told her then, as I tell every student, that do not worry about it.
Hmm.
You will
Somebody
be
will beat
Rajni. Thank
Rajni's
you.
record. Yes.
That is the spirit. I would love to
Well
see
done.
that.
Yes.
That
Yes.
is the spirit because she beat me. And the first one in what, 7 years. I've had plenty of doctors with 12 stations. One even wanted as far as asking for a remark for one of the stations, not because of anything else. He just wanted a 13.
Hmm.
So they've done it.
Hmm.
Anyway, so if you have any, so because she has a long flight tomorrow, if you have any questions for her, we can do that first. So is there anything you want her to explain or what was her plan?
First of all, ma'am, can I say a few words?
Sure.
I cannot thank you enough, ma'am, from the bottom of my heart.
You're
I
welcome.
have to tell you, while doing the exam, I had you in my mind. I could hear your voice inside me. Like,
The
uh,
emotions?
see the patient in front of you. That was like number one. Like how you always tell me, you have to see the patient, you have to respond to the patient, you have to listen to your patient. Like that was there in my mind the whole time. So, ma'am, I can't thank you enough. Uh, to be honest, I was just praying for 9. I just wanted to pass. I just wanted 9 out of 14. I just wanted to get through this exam and not have to do it again because I know how hard it is and how everybody struggled, facing this. It's a lot of stress. So, thank you, ma'am. I can't
You're
be
most
grateful enough.
welcome.
I am very, very grateful.
It takes two of us to work together to get this. I can teach as much as I want to, but if you don't do your part, because every case involves you studying and then practicing it
Mm,
yourself. So
mm,
me teaching and you not studying will not give us the result.
mm, mm.
It is both of us working together for the final outcome. The outcome is that you never ever have to sit for this exam.
Yeah.
And there is no exam in life after this that is this hard.
Mm,
That I can tell you. It is the exam, any of your specialization that comes after this, because you only have to study what is meant, the actual specialization courses, nothing more.
mm.
But this
Yeah.
one was like, what all did we have to study? Oh my dear Lord, it was impossible. So if you
Mm.
have any questions, what material? Okay, Rajni, they're asking questions. You want to?
To be honest, a lot of it was guidelines, because ma'am would tell me to prepare on a few topics and then I wouldn't know what to do. So I would go to Google, type in the topic and Australia guidelines, and then read through most of the top guidelines, therapeutic guidelines. Like I had the account because I was lucky my husband is working in the system, so he's got the account. So I had therapeutic guidelines. So I would look at all the Australian guidelines and read from that. That was my main materials. And then I had my own notes. I made my own notes. And ma'am would always say to make short notes, not more than 1 page or 2 pages. So I would make my own notes so that I understand it. And then when I used to present and do cases with ma'am, she used to give me a lot of pointers. So I've written like stuff all over in my notes. When like she'd give me important points, you mustn't forget these red flags, like important things of that topic. So it's important to study the topic in detail. So most of my material was that. Then I also used the book. Ma'am had given me the Edmonton, the PDF. That's like an OSCE based. Yes, that's an OSCE based book. Then my friend gave me the Murtaugh's. I've got the Murtaugh's textbook.
तू हर जगह पे पहुंच जाता है अपने टावर बनाते बनाते.
Somebody's.
No, that's okay.
Yeah, so it was all over the place, to be honest. I didn't have one source. And ma'am would also give me a lot of links and like a lot of guidelines she would share. And some of her masterclass notes. I used the your OBS notes, the stop topics, the 50 topics you need to know. And that one, I kept using that as my reference to go back and learn those topics. Yeah.
Any other questions? Anything else for Rajni? Okay, so the material wise, one of the biggest mistakes a lot of people make is that you think the material or any prepared material will get you across. It won't. You need to have the knowledge, and Australian guidelines is something you really need to know. So when I gave the exam at that time, AMC was very particular about oral contraceptives. Those days they would ask about the indications, contraindications, and all. Those questions are not coming as often now. There was a guideline that had 150 pages, and I read it. In my life, I would have never spent more than 10 minutes reading something, but I sat and read all of the 150 pages. If my mom was alive, she would have had tears in her eyes of seeing me reading, spending that much time reading something. I'm known as one of the laziest person on earth. I like to spend very little time doing something. I think it was Steve Jobs who said that if you want to get something done, ask the laziest person to do it, and they would find the easiest way to do it. And that is based on me. Seriously, I don't want to. But I did read 150 pages. And I remember thinking, what has my life come to? I'm from Malaysia. I have a very good job back home. Why am I putting myself through this? But it is worth it at the end. It's an incredible country to live in, and it's an incredible place to work. And you get to meet so many lovely people who become your lifelong friends. Worth every bit. Did you learn structure for every case or put cases in a free structure? We never had a structure, right?
So according to you, the patient will give you a structure. So you would always tell me, have a structure, like have an idea of red flags and important points and important things you had to rule out. Depends on the case. But how do I say? You have to adjust the structure. You cannot stick to one thing only. Like that's one thing that we were a little bit flexible with. And I remember the counseling structure that you told me about. What is a problem? Why is it a problem? What can we do about it? And what if what will happen if you don't do anything about it? So like that was always there in my mind. It made it very easy in counseling stations. When there's a problem, you want to try and explain to the patient what the problem is, why it is a problem, and what we can do about it, the different options and the treatment and the things available for it. And what if we don't do anything about it? Like even the patient has the right to say, I don't want any of this treatment. So we have to tell them what can happen, worst come. And
the red flags you need to look for at discharge.
So that was one thing I used. When you use open-ended question and history, do you get most of the details in the role play? So no, to be honest, you just get an idea of what the main complaint is. That's what you get in the open-ended question. Then you have to explore that complaint a little bit more. So whatever that complaint is, you'll have to deep dive and ask more and more about that. So that's, yeah, unfortunately, there's no easy structure. I wish I knew a easy way to tell you guys. And ma'am will also say there's no one formula for everything.
And I think that is something all of you need to remember. That is also why I always say, because a lot of you learn a structured approach for the case, and that will not work for AMC Clinical. It actually will not work for any of the OSCE cases. 4 minutes. How you proceed? What did you do?
Okay, so 4-minute history, you have to ask the red flags. So as soon as I entered the station, like I read the stem, I have an idea of what the topic is at least, and the important things that I need to rule out. So in that little bit of history, I wrote down, like while I'm talking to the patient, I've introduced myself. First thing I write is the patient's name. Ma'am told me that always remember the patient's name. Don't go again and ask what is your name again. That's bad. So I would write the name first. Then I would write like just few things, like 2-3 things that I remember I need to ask. Like for example, the psych question, I just wrote MSA, hallucinations. So I wanted to ask about mood, sleep, suicide, appetite. Those important questions you need to ask about. So I wrote just a few things that I will understand. Then for the groin pain case that I did, I wrote the whole Socrates. So I wrote it down, like the things you have to ask in the limited amount, because unfortunately you will forget or you'll get sidetracked or yeah. So 4 minute, you have to be really, really, you have to concentrate on what you need to say. So
the next one I would answer, physical examination should fast or be accurate more. So no examiner is checking how accurate you are. Because if you come to the hospital, you see our doctors, we have different ways of examining the same patient. There is no one right way or the wrong way. That is number one. So it is how you systematically examine is all that matters. Now for chest expansion, I need to see that your thumb is loose and is sitting somewhere in the middle. So you are moving the hand and you can actually see the expansion. Where you're holding, it matters nothing to me. So it's not the accuracy, it is the process. You understand what you're doing. That matters for the examiner. Okay?
And clinically relevant, like to the topic. So according to what they're asking, you have to do something related to that. No point doing other things, and then they will think you don't know what you're doing. They will assume that.
And about writing, yes, you have to write when you talk to the patient because it's called the grounding theory. So you keep your concentration running through easily when you write. And the important points that you forget, often that is the one that you need to write. And also as an exam, I'm not an AMC examiner, I'm a university examiner. But when you leave the room, the examiner has to set the room back to how it is. And I always check what you have written because I have to throw that paper away. I always check. Like, for example, so all of us who are examiners, whether in the AMC or in the university, we all have gone through the OSCE ourselves. So any of your AMC examiner, if they studied in Australia, they will start going through OSCE in year 1, year 3, and year 4. Or if you come as an international medical graduate and gone through the standard pathway, they have done the AMC OSCE. Or if they've done WBA, they've done the WBA part of the OSCE. The last one is the specialist. If the consultant has come here on a specialist pathway, while they're going through the training program, they have done the OSCE. So every examiner has gone through it and they are there to see how you do your work. So in case if I have seen a student that was very nervous and didn't do something critical, I always check to see if they at least thought about it. And I will weigh the pros and cons of if I need to make them borderline pass or fail. So always use the paper, always write things down. And it's also good practice for doctors to write things down. We do. Okay, anything else? Any other question that needs to be answered? Okay. Is there anything else? Any other advice you want to say?
It's kept on the table. It's right there on the table. There's a paper and a pen.
Yeah.
So
And as soon as you leave, I will throw that paper and I'll put a fresh paper in and a pen. Okay. Any other advice for you about advice from you?
Also, not to write too much. You don't have time to write too much, and it's just to remember like few points. If you have mnemonics, write them. If you have important points that you want to ask, write them. So I wrote like for pain and things. I wrote Socrates, and I made sure I asked each and every. I was very thorough with my Socrates. Then I used Vindicate in my mind here and there just to make sure I got some different differentials. So remember your differentials if you can write them down. Please advise for female attire. I
Well,
just wore
whatever you want to. Or
yeah.
the only condition, the only thing that you need to remember is bare below the elbow,
Mm.
because that is our standard clinical practice requirement. So if you're wearing anything, just roll it up. Your elbow is free. That's all. Wear whatever you want, whatever makes you comfortable. I had 3 outfits that I took to Melbourne. Because if it was a hot day or Melbourne has 4 seasons, so if it was a hot day, this was what I was going to wear. If it was cold, it was what I was going to wear. If I wasn't happy with either of them, I had a third option.
Yeah. And wear something I liked to wear. Like I wore a top that was actually quite old and a little bit like it was actually, ma'am, you know that top is that red one that you always say, that maroonish color. That I don't know. I like that top and I wear it all the time. It wasn't like very, very fancy or anything, but wear something that you feel good in. Like I feel like that's important. Something that makes you feel yourself and feel comfortable. You have to be comfortable that day. So no more structured approach. No, you have to be structured. What I meant is you cannot have one structure for everything. There has to be a little bit of structure. Like ma'am will actually start now about what what she means by you can't do one exact structure for all the cases. You can't. So, but yeah.
The structure way is that you don't go there thinking that if my patient has neonatal jaundice, this is the structure I should follow. Okay. Number one, the examiner is looking to see how you think. They want to see your clinical reasoning process. So if you're going to start there and talk like the doctor before you, or the one before that, or the one before that, then they know you have rote learned. Rote learning will not get you across. It won't. You need to be you. You need to have your strength showing. They need to see how you're thinking, your thought process. So when you start, like if I have, so Rajni, if we have a 7-day-old baby coming with jaundice, how would you start?
So first of all, I'll ask the mom how she's doing. I will always check, see the patient in front of me, like you said. I'll not rush to ask all the things. I will first ask how are you doing, how is baby doing, and then ask red flags about the baby. Is baby awake, alert? Is baby drinking milk as usual? I'll ask about the wet nappies. I'll actually start with that. Then I'll go a little bit more about, thinking about why 7-day-old with jaundice, Allah. You mentioned, yeah. So then, like, I'll ask a little bit more about was there jaundice after day one, and then I'll ask a little bit more about has the jaundice gotten worse. Like, you have to explore the jaundice a little bit in detail, and then ask about where exactly is the yellowing, which part of the body, for how long, and then I would then think about the differentials one by one. I'd start with fever because sepsis is something I want to think about. So I'll ask, does baby have fever, any rashes? Then I would want to ask about pale stools and dark urine. That's quite important to know if it's conjugated or unconjugated bilirubin. Then I'd like to ask about history of the delivery. First of all, ask how many weeks was baby when she was born, was term or not. Then you want to know the delivery. Was there any complications? About cephal hematoma, ma'am will always remind me about that cephal hematoma. Then ask about any family history of thyroid disease. Heel prick test was done. Then, like as the patient gives you a positive, you have to explore that positive finding more. Then you'll get an idea. Okay, this is what it is. You'll get closer to that. Then
That's
you
okay.
have.
Let me ask the group now. So when she said how she's taking the history, you could see how she was thinking? How many of you could see the thinking process? That this was not Rotland. She's actually thinking through and then asking the question. This is what the examiner is looking for. So there is no structure for her to follow. She followed, she saw the baby is having the jaundice, but it's a 7-day-old baby, so the mother first. You always see the invisible patient first. It's the mother. How is the mom doing? Because you don't get a chance to talk later to the mother. So you always ask, how's the mom? Because that is patient-centered. Yes, the mother matters. She's an invisible patient. We always see the invisible patient. So ask, and then you look at all the causes. So she looked at the well baby, so she wanted to make sure, because jaundice can also make the child dehydrated. The child may not be drinking. The question you forgot is breastfed or bottle fed, because you forgot to rule out.
Feeding. Yes, yeah.
Okay. So is the mom, you check the details. When did the jaundice start and what happened? You want to make sure there's no connector. So you want to make sure the child hasn't had any seizures or any of those things. And then you want to keep asking, the last bit is pale stool. And then any family history of hepatitis, any personal history of hepatitis for the mother. So you rule out one by one. The examiner need to see you thinking. Now, if you have Rotland, you have 100 million questions that you have that you're giving at rapid fire. They know you're not thinking. They know you have Rotland. Rot learning will not get you across the station because that will come under global failure. They will hit that. So go easy. You all have the knowledge. All you need is to be present there, listen to the patient and follow their guideline, follow Australian guideline and follow what the patient is telling you. So every 6 months, AMC actually runs training for people who teach international medical graduates. And I actually have to go to Melbourne and attend it. And one of the things the chief examiner always said is the same. If AMC allows you graffiti on the wall across all of your doors, listen to your patient. And that makes sense because most of the doctors do not listen to the patient because you're anxious. You have 4 minutes. You want to get the questions through. You have all these questions in your head that you have learned and you want to get it all out. And all of that is spinning in your head. I actually know someone who has 600-page notes for counseling. You can't have 600-page notes because you can't take that 600-page information to an 8-minute station. You can't. You simply can't. So one of the biggest or the most important thing I insist all my students is that if you're writing a case, you need to write only 1 page. That is what I followed because you can only take 200-page notes to Melbourne and you revise that. I still have my notes that I've written years ago and I'm still using that. Nothing has changed. What are the questions? Can we roll up this long sleeves up to elbow? Yes, you can and you should. Won't we ask you jaundice related? No, the mom first. Always mom. Always
Mom and
mom.
baby. Like also ask like if baby's
Babies well.
baby's
When
alert or drowsy. It's important to rule out urgent things. Very
That's the question. So I'm not sure. When exploring complainant history, if we understand this is not a cancer case, that you still need to rule out the B symptoms. You still need to. So the B symptoms are fever, night sweats, loss of appetite, and loss of weight. You have to, because it's your job to check. Okay, anything else? All right. She has a long flight to go, so I'm going to let her go and I can run the session. Go and rest, Kochi. You've done a lot of work.
Problem. Okay,
I
ma'am.
love you very
Thank you
much.
so much. Thank you, ma'am. Love you too. Okay, thank you. Okay, bye bye. No, I'll actually stay to listen to your talk
Oh,
also a little bit.
sure. Okay, go
Yeah,
whenever you want to, all right? Okay.
okay.
All right. So I should have done this beginning, but this is my presentation. Okay. Before I begin, I acknowledge the traditional owners of the land, pay my respect to elders past, present, and emerging. So I do not have any script for you, and there's no checklist. I'm going to teach you what an examiner do from the examiner's perspective, so you understand what is expected of you. Okay, so first thing you need to understand is the predominant assessment area and the assessment domain. Do you guys understand what these two things are? What is the predominant assessment area and the assessment domains? Anyone knows any of this? No. Anyone else? Anyone? Have you seen the AMC scoring system? AMC explains this in the website. Okay, so the assessment domains for AMC are, they have history, choice and technique of examination, the accuracy of examination, diagnosis, differential diagnosis, choice of investigation, management plan, patient counseling and education, approach to patient and relative. So this is the assessment domain. You also have predominant assessment area. This is done when we write an OSCE case. Now, there are two things you need to remember about this. Now, the same OSCE station, assume the neonatal jaundice that we just did, it can have many assessment domains. If today we decided to see your history taking, tomorrow the same case can come, it will be a diagnostic formulation. And the day after tomorrow, it is going to be probably management, history and management or investigations. So the predominant assessment area can change every time. And that is why when you often see people who pass the exam and when they teach others, what they are teaching is what helped them pass the exam. It doesn't mean that you can pass following the same system because the predominant assessment area keeps changing. So there is no easy way to do this. You need to understand what the examiner is looking for and deliver that. So again, if you have a structure and you rigidly follow the structure, it is very difficult to get through. Okay, so I want to show you what the other side actually do because I am an examiner. I'm not an AMC examiner. I'm a University of Ski examiner. We follow the same structure as AMC. We have the same system scoring, and this is what we do on the other end. So 2 weeks before an OSCE exam, we get, if I have decided that I'm willing to work on that day, I will get the station information in a PDF. I have disclosure that I need to sign that I will not talk to anyone about the case. I can only read it, and that they take it very seriously. Second, I can read, and if I'm not happy with anything or if I worry about something, I can talk to the chief examiner and ask like if there's any problem. On the morning of exam, I get to the exam center, I talk to the marshal or the supervisor, and we have a group meeting. We talk to each other, we talk to other doctors who are doing the same job. And then at the station, I meet my simulated patient. That is probably the first time I would see my simulated patient because this is all organized in advance. So often I would ask if I can do the case with my simulated patient one time. So I'm happy with it, happy with the simulated patient's example. Now, you've got to understand, we're very, very protective of simulated patients. All the examiners are extremely protective of our patients because they're doing a remarkable service. So you need to be gentle to the simulated patient. You need to hear them. You need to treat them with absolute respect. Okay, so I run the case one time with them. If I'm not happy or if there's any changes, I would do that change before you guys walk in or before the students walk in for med faculty. Where am I? Okay. So in the room, we have the iPad. You have your paper and pencils. Anything special that need to be done, that will be there. And then the paper marking sheet. So if the iPad goes down, then we have the paper marking. But I've never ever had to do the paper marking. The iPad always works. So we have few jobs to do. We always have to make sure we have the right student. We check the names in the iPad and the student's tag, because otherwise the marking goes haywire. So we always check that. And then I wait for you to say, you show me your lanyard introduces, and I confirm again. This needs to be done twice, just making sure. Otherwise the OSCE's validity goes down, because we need to have the validity, and that is one of the identifier we always check. So we have 3 jobs to do: domain grading, global scoring, and written feedback. So the domain grading, every OSCE has 2 scoring, which is the checklist score, which is your domain scoring. We have the global score. So that is why sometimes you see people getting 4, 4, 4, and they still fail. And that happens because of the global scoring. If you have done things that are not safe, or something that I think is not right, then I will click the global fail score. And that means even if you pass, even if you got a 777 for that station, if you fail the global fail, you actually failed the station. And I have done it. When the students have done something that is not right, I have clicked the global fail, so that it is not being vindictive, because my job is to make sure this particular doctor or a student has the skill set to treat a patient when they finish their final year. So if they have done something unsafe, it is my responsibility to click the global fail, so that they can be taught and they can get better and then come back and sit the exam. And the last one is the written feedback. So if there is something that I was really, really concerned about, I would write, there is a place where I can quickly type in a feedback, so that the chief examiner knows what I have seen. They can actually see it in the video and reconfirm whatever I saw. And that is done in the 2 minutes when they are outside. What does examiner check in the global score? How safe you are. Have you treated my simulated patients well? Have you done anything that I consider to be unsafe? The language you use, your attitude, your expressions. Are the marks for each station decided after the candidate leaves? Yes, it's as soon as you leave, the marking is done. Because I only have 2 minutes. So when you leave the room, I have only 2 minutes. In that 2 minutes, I need to finish off your marking. I need to put the room back in the original order, how it was, and then wait for you to come in. And the simulator patient, usually they would have to put their shirt back on, whatever, position them right. Or every student has to have the exam in exactly the same, the room has to be in the same condition as the one before. Because otherwise it will change the validity of the station. So how the room was for the first person would be the same as for the last person on that day. Nothing can change. And that is also the reason I get very annoyed. So if I am working in a station that is grading the cervical screening test, and if you leave everything unattended, if you leave everything here and there, I would be very annoyed. Because I have to put it back on, and in 2 minutes I have to put everything back on, so that the next doctor will have exactly the same thing as the one before. So anything that you opened, you closed. Anything that you exposed or you took it away, you put it together, put it back. And it's also a good skill, right? In your real life, do you just leave everything, or do you always put things back? So just these are the marks for each. Yeah, I've answered that. So I hope this made sense. Now, domain-based marking. So assessed against a series of domains. The examiner grades each domain. So we have to do it holistically, and it's deliberately done. So you got to remember, we have 150 medical students every year. 150 medical students have the same staff, the same reading material, the same PowerPoints, and the same system. But in our OSCE, the 150 student, not one of them will sound like the other. Not one. Because they develop their own skill set. Each person is different. I run mock exam every weekend. People do one-to-one mock exams with me. And these are the doctors who don't take my courses, but they just want to have the experience of the mock. And as soon as they open their mouth, I can tell within the first 10 seconds what course they took. And I only do it so I only see so many less number of cases as opposed to an AMC or SCI examiner. Because everyone who attends any particular course will sound exactly the same. Use the same words, same structure, and the same dialogues, and everything is same. And that is very difficult because you can't see who you are. You can't see your thought process. How to grade you if you can't see any of those? So you need to develop your own skill set, and that is important. So the global scoring, a lot of people don't get the global scoring. So the speculum, if they have only one speculum, you just clean it and put it on the side. If they have multiple speculum, you will dispose to one. But I believe AMC only has one, so you put it on the side. But make sure it is closed and exactly where it was when you started. Our cervical screening station will have one for each doctor because they need to open the pack, so it is already pre-packed. And then after that, we package it for each of them later, again for the next set. So global scoring system, the overall, so we have the clear fail, borderline pass, clear pass, and excellent. So why do we need the borderline fail and the borderline pass? Anybody knows? This is actually your average score for the domain. So in the AMC marking criteria, you can see the average score that comes from borderline fail and the borderline pass. So if the station, if everybody did, you can see the borderlines, everyone did well, the borderline score will be very high. If everyone did poorly, you can see the average score is sitting close to 1 or 2 of that 4. That's why we need to. So it's for the regression scale, and that's why we are using this. So the borderline candidate demonstrate a clear structure and able to summarize their finding. So if they can do it, they are in the borderline. But borderline pass is fairer than borderline fail. But it is not going to be a pass. It's just for the average score. So the marking checklist usually we have is that we observe how you treat the patient, how you greet the patient, your introduction. And I know a lot of other courses say that you don't have to ask the patient's name, it's outside. One of the key things for us, at least in the university side, is that the right patient in the right place at right time. So we always insist that the doctor checks the patient's name again and the date of birth again. And that is a good habit. So I did for my AMC or SCI, I did ask the patient confirm their name and their date of birth because right patient, right place, right time. And then clarify the nature. So what exactly is the reason? Do they say their date of birth? Yeah, I asked them. All simulated patients are taught. It's in the script what their date of birth is. Appropriate infection control. Yeah, hand sanitization is a big thing. And now for procedure skill, washing your hands, putting your gloves on. So remember that in the physical examination station, so there will be a hand sanitizer and your gloves. Between the two, you would find the tissue. Yeah, they will say the age. I know they will, because we write that. So wash it when you're sanitizing your hand, after you hand sanitize, use the tissue, wipe the hand sanitizer off your hand, and then put the gloves on, because it's much easier to put the gloves on if you don't have hand sanitizer in the hand. So use that, and that will make it easier. And inspect you. So if there was a urine inspection station, follow the protocol and then do how to do it. If they're asking you to do the urine dipstick, you need to do the correct protocol. And if there's any interpretation to be done, you do it, putting the timer on. So urine dipstick is one of the stations that has one of the highest failure. You can always see the average score for that domain is very, very low. And it's such an easy thing to do, and yet many doctors fail. So learn how to do. There are so that I have to tell you. There are a lot of stations that are called the low-hanging fruit. Low-hanging fruits are the one stations with minimum effort you can pass. Very little effort. So the first thing I did when I prepared for the AMC exam was to identify all the low-hanging fruit, and I studied all of them. Low-hanging fruit means that in a tree, the fruits that are on the lowest branches are easier to grab than the higher branches. So I wanted to get those stations first, so I identified every single one of them. I studied them and I got full marks for them because I put my heart and soul into it. So the urine dipstick is one of the easiest stations. Prescription is easy, urine dipstick is easy. What else? How to take the blood pressure. So AMC uses a dial blood pressure apparatus. I never knew how to do it. And a friend of mine who is working in a hospital 4.5 hours from my home told me their hospital has that machine. I drove 4.5 hours just to practice on that machine one weekend. So I did it. My preparation was like going for a war. I was ready for it. I prepared for it. And that is exactly how I teach every one of my students, that you need to be ready for this exam. You need to put your heart and soul into it. There is no easy path. Imagine driving 4.5 hours one way just to figure out, because the one with the dial, the BP apparatus, the knob to control the blood pressure is very difficult. And I didn't want to open it too much and lose everything and then do it again, because if you do it a second time, they will fail you because you're harming the patient. So I wanted to have the practice. So I went there, practiced it, and I came back home. So that is a lot of work I did to pass. Okay, diagnostic history. So you want to know what the patient's history is. You want to know the story. Urine dipstick station, everything goes wrong. So people don't identify the patient's name. They don't know how to they don't check the expiry date on the bottle. They don't close the bottle right after they opened it, took the strip out. They don't know how to dip it in the urine. They don't put it on a tissue on the table. They don't start the timer. They don't read it properly. And then they didn't do the macroscopic part. Comment on the, yeah, there we go. Correct. Okay, red flags. And so the diagnostic history, the story, the sequence of events is very important. So if you look at the AMC scoring, you can see that the sequence of the examination is important in many places. Many of the history and diagnostic formulation, they want you to follow the sequence correctly. So that's why that sequence of events is important. Ideas, concern, and expectation. That is something I used, and that is something I teach my students. Symptom analysis. So if the baby has, or if you have a dysuria, you want to know when did it start, how did it start, did anything happen before that, all of that, including that do you insert anything into your penis for masturbation or anything like that? All of those questions, all the way to the end, from beginning to the end. Red flag symptoms are important, past medical, drug history, social, family history. This is not really important. I've only ever worry about family history if I am talking to my patient about colon cancer, and then social history. If now they're asking for, today's case, there was an occupational therapist assessment, that I would need the social history. And then drug history, if I'm concerned about any side effects for anything that I'm prescribing, I ask that. Communication, it has to be non-judgmental, and you need to know about unconscious bias. Unconscious bias is how your facial expression changes. Your simulated patient is watching that, and that matters. The examiner won't see it, but the patient would see it. If the patient says that, oh, the doctor was very mean to me, and that is very likely that the global score will be clicked. So do not have a bias. Do not have the unconscious bias. Read unconscious bias, you'll understand what I'm talking. You always explain in simple language. So a lot of people will say, I'm sorry for the jargon. Do you have high blood pressure? That's not a jargon. Jargon is too high. You don't have to keep saying that, oh, this is a jargon. Most patients are Australians and they do speak English. Just keep it simple. Did you have any struggle with any of the history, Rajni? Any jargon problem?
Yes, ma'am. To be honest, the groin the groin pain case, he under Socrates, under radiation, that he showed like his suprapubic lower abdomen. So then I thought of bladder injuries. Then I asked him, have you noticed any blood in the meatus? I said meatus, and he asked me, what is meatus? And then I said, I'm sorry, I shouldn't have said that word. It's not like it's a medical term, but I meant the tip of the penis. So I specifically said that.
But he did say suprapubic.
I didn't say suprapubic. No. He pointed to that area.
Oh, okay.
When I asked him about radiation, he pointed to his lower abdomen. So that is why I thought maybe he might have had like a direct bladder injury or something. That's why I thought of that. Then I asked him, "Did you see blood in the meatus?" Like as a fool. But then I corrected it, and I told him, "Have you noticed any blood in the tip of the penis?" Yeah.
Because in the clinic we normally ask, right? Have you noticed any blood at the tip of your penis?
Yeah.
How did you revise all the subjects before your exam, Rajni?
That is a very good question. To be honest, I went through the topics that I felt I was actually confident in. I felt like whatever I know, I must know really well. Like, so I went through topics that I knew well, and I did a little bit of revision of PE, because you forget PE steps. So I just went through a few PE steps last minute, and psych. I think psych and counseling, these two also I went through last minute. So it's very difficult to go through everything, but you have to choose your topics that you want to do well. And like psychiatry, I didn't want to mess up because I'm not good at psychiatry, but I studied a lot of psychiatry for this exam. So I actually passed both my psychiatry cases, so I was actually happy. So, yeah, depends on what your subjects. I mean, you must decide what you want to revise. Yeah,
But you have to agree, this exam makes you a better doctor.
that is very true, ma'am. That is one thing I really learned a lot about the Australian system. I can't I'm waiting now to get a chance to work, because I'm sure it'll all come to some use when I'm working, and it has helped me like open my mind, because I was only working in internal medicine before. I lost touch of obs and gynae, and like I felt like a medical student again, like, which is a good thing, because
Yeah.
all of us went through that. It's good to remember where you came from. So
Yeah, all the things that I didn't study or that I didn't want to study when I was a medical student, I had to study for this exam. It is like you can't escape. It will come back and bite you. So I was very surprised. Things I had absolutely no interest in studying, actually studied for this exam. So the one thing I wanted to tell about the how to study or the subjects you study. So like I said, I'm from Malaysia. So I come from a country that thrives on gambling. Okay, so most of my family members are Indian, so the Chinese Indians. So gambling is part of our lifestyle, and we like to figure out how to better our odds. And as a child, as an adult, I look at my odds. And one of the things that I learned for AMC exam is that if you know all of your physical examination stations, there are 72. If you know all of your counseling stations, if you know your obs and gyn, and then psychiatry and the peds, you will pass the exam. You will get about 9 stations. But you must know all of them. You cannot take a risk not knowing any of them. So I knew every single physical examination, every single one of them. Every morning I get up at 4:30, I walk my dog. So I would recite every single one of the physical examination station. I would say, okay, I'm doing the cardiovascular system, and I would say in 8 minutes how many or all of the things I need to say. And I continued with that. I did all of my psychiatry. My goodness, I hate psychiatry, but I studied every one of them, and I could do any of them even in my sleep, Counseling, I did every single one of the counseling stations very well so that I can score without worrying about it. Peds, or obs-gynae, or. That's it. And you would score. Because Gen Med is so huge. If I got it, I would still pass, but I'm not going to spend a lot of time doing it. Handbook 2. I have not looked at the handbook. You can see on my shelf, I have the handbook. It is my auntie's handbook. My auntie was a general practitioner in Malaysia. At the age of 50, she decided she is retiring and she was migrating to Australia. And in 1994, or maybe later, she had 500,000 Aus dollars to put in the bank. I am still envious of the fact. And so Australian government gave her a family, the entire family PR to come to Australia. She came to Australia to retire. She stayed home for a month and she decided that's not what she wants to do. And she gave the AMC exam, passed in her first attempt at the age of 52 or 51. And my uncle, who also wanted to travel around the world, who was also a GP in Malaysia, was forced to sit the exam and was forced to work another 20 years. And he also had to get his RACGB fellowship. She had fellowship in Malaysia. It was not, both of them had fellowship in Malaysia. It was not recognized here. So they did it again. So I have her book here and I have never looked at it. The handbook, I have kind of OCD. I can't go through the handbook without having my OCD activated because I like things in an order, in a structure, and that book will drive me insane. So I haven't looked at it. Rajni, did you use the handbook?
No, ma'am. I got it. I actually bought a second-hand copy, but I also got very frightened by it. So,
It
yeah.
makes me very anxious seeing that book. If I have to use it, I'll have to tear the book into pages and then glue it all back and then redo it again, and I won't be able to do it. I can't do it. So I never looked at it. I have a page in it that I have meant to read it before my exam, even while teaching. It is the vertigo patient. I still have the bookmark on it. See, this one. I was meant to read it and I have not read it. It's still there. Because they have a case for the patient with vertigo physical examination. I haven't. What's the groin pain case, doctor? I heard patient was using a lot of bad words. Patients can use bad words, so what? Rajni, did you have a problem?
No, actually, it was my first case. Maybe he wasn't ready for me. I don't know. He didn't say any bad words to me. I was actually quite empathetic also. I kept telling him, are you okay to talk? How's the pain? Can I give you something for the pain? And then he said, no, I've got something for the pain, but it's still quite bad, doc. He graded it 8 out of 10. So he was in a lot of pain. Yeah. The case that I got, it was he had a direct injury while playing basketball. And he said, when I asked him about swelling, he mentioned the scrotum feels swollen and it's red. So then I came to the conclusion it was testicular torsion.
No, you won't have to. Sorry, I was just reading that. No, you won't have. That's the reason why I didn't want to do it because I'm not going to do hint examination in under 8 minutes. Injury to the private part. Okay, so what was I going to say? Now, the patient's talking bad words. Yes, they can and they will. They have to because they're testing to see how you react to it. In real life, we have patients who will talk to us badly. That is life. Why are you afraid? De-escalate. You are a doctor. You're trained to de-escalate. All simulated patients are actors. And if you have attended my sessions, sometimes we have, I do run sessions with our simulated patients from our university. And you can see, Rajni would know, Libby is one of my simulated patients. She's been a simulated patient for 30 years. She can cry on demand and it looks very real. I think Karam is also here. Karam also has seen.
Yes, ma'am. I want to And that Breaking Bad workshop really helped me, ma'am. I was so nervous. You know how nervous I was. I was literally shaking, having to break such bad news to the patient. And Libby was amazing. She was an amazing, scary patient. But like, I felt like maybe doing all those workshops with you and exercises really took the anxiety out of it. Like, I was a little bit more prepared to face anything like that. That really helped me, I think.
All simulated patients are trained, absolutely trained actors. So
Mm.
Libby is in her 60s. She can cry on demand and her cheeks can turn red and you can see tears. I don't know how she does it, but she can do it. And she would do that 40 times in a day,
Mm.
every 6 minutes. Again, that is incredible. Yeah, Darlene also says, yeah. Okay, so the hemodynamic stability, this is something that drives every examiner insane. So what that means is that when you are tested as a junior doctor, or rather an intern. The person who is sitting there marking you is a consultant. In the ED, assume you are in the ED, you have a patient to take care of. Are you going to turn and ask the examiner, is my patient stable? And still expect to pass the exam? You don't. You never ask. It's your job to check the stability of the patient. That is why we have junior doctors and not using robots to do our job, right? You cannot and you should not be asking. It will drive the examiner completely insane if you ask, is my patient hemodynamically stable? And that's why in the last few weeks, you would see all of the cases, they are actually giving the vitals outside because they are absolutely sick and tired of hearing doctors asking, is my patient hemodynamically stable? Okay, how should we handle a situation patient is extremely arrogant towards the candidate? Never take it personal. It is their job. They're checking to see your reaction. In real life, you're going to have patients who are going to be rude to you, to be
Um,
arrogant to you.
I remember what you taught us, ma'am, that to name the emotion. Like if they're angry, you can say like, I can see you're angry, but I'm here to help you. Like, you can calm them down by saying, okay, I see you're upset, or I see you're angry, I see you're irritated, or you can actually name the emotion and tell them that I'm on your side. I'm here to help you. I'm going to stay here with you no matter what. Keep reassuring them and try to de-escalate.
We don't shake hands with the patient, no. They have a bubble. You don't encroach on their bubble. You don't have to shake the hands. But when I left the room, I always thanked the patient. And I also, one of the cases I actually did pretty badly, or rather, I thought I did badly. I told the examiner I would fail myself. So it's okay, you can fail me too. And he burst out laughing because I don't think he ever heard someone say that. But I was upset with myself, so I needed to say it. So I told the examiner I would fail myself. Because physical examination is my skill, I'm pretty good. I also teach that at the university, so I'm good at it. And I had peripheral vascular examination. They didn't ask me to do peripheral arterial, they didn't ask me to do peripheral venous, and they asked me to do peripheral vascular examination. I thought, And in 8 minutes, and patient didn't have any varicose vein, so I said I'm skipping the varicose vein part, but I would do the arterial part. But there was no sense of satisfaction during that station, so as I left, I told the examiner I would fail myself, and you can fail me too. And that was the first time I actually saw someone burst out laughing. He genuinely laughed, and he thought it was funny. Oh, so what to do? Where is it? Do you have to? No, you just say hi. My name is Dr. Verghese. What's your name? What brought you here? I know you're laughing, Karam. And I think I made so many people laugh on the day of my exam because when I'm nervous, I crack jokes. So maybe that was one way of me coping with it. I had the gender dysphoria patient. I finished the case in 6 minutes, and I had 2 minutes to spare. And he was wearing a blonde wig. In those days, they didn't ask you to leave the room if you finished early. So, patient had a blonde wig and a nice, colorful Hawaiian shirt. And I told him, "You're lucky you can match your hair to your outfit. Look at me, I have this boring hair. I can't do much." And then everyone was laughing. The patient was laughing, the doctor was laughing, and I was laughing. I talked to the patient for the next 2 minutes after I finished the station. So I think now they ask you to leave the room if you're finished. Correct? Did I ask you to leave? Oh, Rajni is gone. Oh, Rajni, did I ask you to leave? After, like if you finished early or you finished everything on time?
I finished. I took most of the time. I just stayed back and I kept looking at the questions and just checking again. I also kept talking to the patient, like you said. I just went on and on and on till the bell rang.
Did you run out of time for any station?
The physical exam,
Mhm.
which was 7 minutes diabetic sensory neuropathy. I mean, it said relevant physical exam. It didn't say specifically diabetic sensory, but that took time because I had to keep explaining to the patient, I'm going to do this. I'm using cotton, close your eyes. Then I'm going to use a tuning fork, close your eyes. I'm going to use a little hammer. It's not going to hurt. That took time, I guess, trying to explain to the patient.
Mhm.
And so that I went into the last minute because she said time's up, the prompt time, and I had only 1 minute to tell. But I quickly completed it, and then I told him the diagnosis. So I had to rush a little bit.
Did they have the prompt time for every case? You didn't
Uh,
have any dramas, right?
the like some history case, they didn't have exact prompt timer.
Okay, and I can explain why. So I am responsible for marking you, or rather, in our OSCE, I'm responsible for marking as well as keeping the check of the time. So we have a timer, and in the iPad, I can only put two separate timer when we're using the software. And if the station has 3 or 4, I have to reset it every time, and often I would forget. So it is your responsibility to remember the time. So I live in Brisbane. I used to work in Gold Coast. So when I'm driving in the morning, every morning, I would look at the clock when it turns and then I would count in my head. So I train myself 3 minutes, 5 minutes, and 7 minutes. So I knew in my internal head that when it's 4 minutes, when it's 3 minutes, 5 minutes, 7 minutes, all of that it was in my head. And that is how I kept, like exactly how you prepare for a war. I wanted to pass the exam in my first attempt because I couldn't afford to pay for this exam again. I have 3 kids and life is very expensive when you come in as a new migrant to this country. It was not possible to sit again and I couldn't risk losing my career. So I needed to pass in my first attempt. Going to Melbourne, staying in a hotel, all of these are expensive affairs. So I wasn't going to sit again. So I did everything that was needed to pass the exam, everything, including driving 4.5 hours to learn how to work a BP machine. I was not going to take a chance. Okay, so we're here. Next one would be keep looking at the task, important. Yeah, you do need to know the task all the time. The hawks and doves, so some of the examiners are like hawk, they watch you. Some are dove. I am the dove type of examiner because I don't want to stress the students further. So I normally would never get up and go and see. The only station I would ever get up to do it would be cervical screening test. I would need to see that they visualize the cervix. So that I always check. But other than that, I am the dove. And we know no examiner is going to be like another examiner. We all have our own personality. So hawks and doves, you know that they exist. They now show the predominant assessment area on this career. No, they won't show. They can't. It'll change the validity. They can't show that. I don't think so, unless they change the guideline. We don't show the predominant assessment because it has nothing to do with the student. It is for us, the marking. The halo effect. So years ago, when I was sitting as an examiner and I was examining an X-ray station, And there was this guy came in, and as he came in, he introduced himself. And as I sat, and he was still looking for the X-ray, I saw his shoes. His shoes was well polished, like mirror glaze polish, and the pant had a single crease. And that means he spent time ironing. You know, I'm a mom. You notice things. So he must have spent time ironing it very well. And then he sat down and he did the station so well that I actually forgot to mark him. I was mesmerized. It was probably one of the, I wish I had recorded it, one of the best X-ray station I have ever seen anyone read. And then after he left, I frantically marked, gave him a 7, and I actually recommended him for the university award, and I remembered his name. 10 years later, he is my son's brother-in-law. And I remembered his name, and I told him I was his examiner, and he remembers me. So you do notice the students. So that is a halo effect, that little crease on the pant and the shoes that are shining, and then doing the exam. So there are some things that we remember, and the halo is the first impression, is always carrying the weight. So you need to remember how a lion hunts. Actually, the lioness hunt, male lion doesn't hunt. So it stays quiet, it watches the prey, it finds the weakest prey, the one that is away, facing away, so that it can't see when it comes to pounce. But a lion will never ever hunt the strongest in the group, the animal. Lion will always go for the weakest. So when you're coming in, your first impression matters. If you're going to come in all scared and nervous and worried and doing everything all over, I am going to watch you like a hawk, because that is my job. But if you come in confident, like that boy comes in confidently, sits down, and then does things what he's meant to do, systematically and precisely, the examiner will relax. Yeah. So if someone passes 8 cases and 2 pilot, how do you pass your pilot case? You don't pass your pilot case. You don't know what your pilot cases are. We don't grade the pilot. So you can't recorrect. And 99.9% of the time, there is no point asking for remark. There is no point. The reason is, give me a second. I'll show you why there's no point for remark. I have the effect here, maybe. Let me just go through this, and if I haven't answered that, just remind me, okay? So what the pilot cases are not assessed. It's never. So you will not. We don't mark the pilot. We don't know which one is a pilot. Only the chief examiner knows that, but it will not be marked, so you cannot ask. And if you got an 8 station, nothing you can do. If you miss anything important other than predominant, do they fail? Yeah. Global score works for anything. Anything. So you need to meet all the criteria together. So whatever the door stem tells, you need to read every task carefully. So recently there was a case, it had psychosocial history, and the doctor who took the exam read it as psychiatric history, and he did an MSc. There is no saving for that. If you don't read the station properly, you can't pass the exam. You need to read. You need to stay calm, read it. There is enough time to read the stem twice, because that's an OSCE requirement. When we write a station, we need to make sure that the person who reads it can read it twice. So stay calm, read the whole station. The setting, you always need to where you are. Are you in the ED? Are you in the GP practice? Are you in the rural setting? The next is the patient context. Whatever the patient is doing, how old is the patient? If AMC tells it's a 10-year-old child, you need to know why it's a 10-year-old child. There has to be something you need to find, because they've given that age for a reason. So if the 50-year-old male, you need to think, why 50? Why not 10? Why not 20? And then any occupation, anything like that. And I only follow Socrates and Vindicate, and these are the 2 things I've used for all my exams, and this is what I teach all the doctors who come for my classes. So STEM does not tell you is that which domain. So they normally do not tell you the domain. And then we follow the Dundee format, which is the assess, how accurate you are. Accurate is not holding the chest in the right position. Accurate is that you don't make a mistake. So Rajni made one mistake where the GDM patient postpartum, she said FBS and it's OGTT. So that is the accuracy they're looking for. The skillful, how skillful you are in doing things, and then how supportive you are to the patient, to the system, everything there. The efficient, how efficiently you have handled this situation, such as breaking the bad news. Have you done it following the spikes protocol? And structure. Structured means not following a rigid system. Structured is that, like, for example, physical examination is going to be inspection, palpation, percussion, auscultation. That is what structure is. So if they have asked this question, so this comes often that the patient has HPV positive and then CIN2, the task often tell you to talk to the patient and counsel. What you really need to know is that you cannot counsel a patient without taking a history. Everybody makes that mistake. You go and start counseling. I've had people say about, like, if the counseling about chlamydia, they're telling me it is a bacteria, it is this, it is that. I am not writing the next thesis as your patient. Tell me what I need to know. Do I care if it is a bacteria or virus? Do I know the difference? I don't. Why are you giving me a lecture then? Tell me exactly what I need to know as a patient. If I'm a 17-year-old, you tell me what I need to do. How should I take care of myself? How should I protect myself? How should I protect my partner? Those are the things I need to know. I don't need to know whether it's a bacteria or a virus. It makes no difference to me in the grand scheme of things. Don't give me a lecture. And that's what your patient is expecting. Then what? So this is what you do. The setting shapes the work. Yeah. GP, if it's a GP, you are asking the patient why the test was done and then talk to the patient about the result and what we need to do next. And it is the patient's choice. I know someone who had the NIPT and it was a trisomy, and then the next step, she said, you have to do the CVS or the amniocentesis. And now that is fundamentally wrong. Why? Why is that wrong? If I haven't made all of you sleep, you got to tell me why that is wrong. Why you have to do amniocentesis or CVS as your next management plan is wrong. What is a patient-centered approach? Patient choice, yeah. You don't have to. You can do it. Yeah. Patient has the autonomy, and that is the most important thing you need to remember. They have the autonomy. You don't have to do anything. So their option is do nothing, go home, think about it. If you want to do the confirmatory test, we can do it. We support your decision either way. So always remember patient autonomy. You've learned all that for your AMC1, so you must practice that. So you always need to ask, what did the patient come in for? What is the presenting complaint? If the STEM says patient has dysmenorrhea and that we have done all the investigations are normal, there is a blood picture that shows IDA, the presenting complaint is IDA. No longer dysmenorrhea. The previous GP did the full history, ordered the test. You have the report. The report says IDA. You need to rule out other causes of IDA before you say that your IDA could be because of your dysmenorrhea. So that is what you need to know. What did the patient come for? What is your presenting complaint? And what is AMC expecting from you from this particular situation? Deliver what is expected and you're good to go. So you read it, you name it, you pivot. So read where you are, read the stem, read the setting, read what the SB is telling you. I had one doctor who had, the patient had costochondritis. Patient kept saying, I have pain here. And the doctor did not look at it. Even multiple times the patient stood, I have pain here, I have pain here. But she was fixated on acute coronary syndrome and all the others and failed the station because it was costochondritis. So read the SB always. They are there to help you pass the exam. They actually are actively invested in you passing the exam. They're good people. And if they're rude to you, that is their role. Don't take it personally. It is to see how you react to it. Read your own eyes. What fears is coming to you, deal with it, because you need to be confident and articulate. Read the stem. Okay, name. So you name the predominant station. So when I read my station, I looked at it to see what could be the thing that AMC is looking for because I wanted to deliver that. So I was careful in my approach. So my protocol was I would first check where am I? How old is my patient? Why that particular number? Is my patient going to die in the next 10 minutes? If the patient is going to die in the next 10 minutes, even if the stem says do the history and management, I would do the management and then consider the history. Because that's my role as a doctor, and I would do it. So you name the predominant station in your head, name the domain in your head. You need to think what the domains that they're looking for. Name what the patient needs. If the patient requires further information, I would provide that because it's my job. And each time I check where I am because there will be 3 or 4 criteria for me to, or 3 or 4 tasks I need to do. And I will strike them off as I've done because the screen is in front of you. So you can constantly look at the screen to see if you have forgotten anything. You must finish all of the tasks. If you don't finish any of the tasks, if you get a 0, you fail the station. So make sure you must finish the task before the bell rings because anything that you say after the bell rang, it's not counted. Because it has to be same for every doctor. The don't miss, the safety net, red flags are important. So the pivoting is that sometimes when you start a case, you think, okay, I'm going this direction, but halfway through you realize, I'm not going in the right direction. You need to pivot very quickly. Very, very quickly. So sometimes when the examiner gives you the result, and it is not what you are hoping for, or is not what you thought the case is going to be, pivot. No one is expecting you to be perfect. None of us are. You're allowed to make a mistake, and you can correct it by correcting it right away and say that, okay, I haven't asked this question. Is it okay if I quickly check this? And often they allow you. You pivot when the SB shows an emotion. If the SB is sad or simulated patient is sad, or they said, I'm really concerned, I would say, I can hear you. I can see that you're concerned. Let's work together and figure out what is going on. If they say that my daughter passed away 6 months ago or 1 year ago, I would say, I am so sorry for your loss. I will name that emotion. I do. The only part you don't pivot is that you don't go from presenting history to past history and then go back to presenting history and then go to future history. Don't do that. It will annoy every examiner. So don't do that. So patient came for, what is AMC expecting? The recipe follower is the person who has a structure and they think the structure will save them. And then when they go in there, the case and the structure do not match, and then you will lose. The result, you lose the history. So you always need to read the station, name the station, pivot. If it is MSC, or if the parent has come or you want to talk something, ask what it is and then manage that station. Like the father is saying, oh, how dare you keep my son? Manage that. It's your job. You are a doctor. You can handle stresses. They check in to see how you handle cases. Next would be, I have to rush a little bit. Escalation phone call. So if the nurse is calling you, it is often because you are supposed to escalate the case or manage the case. Most of the time, you manage quickly, and then if there's a need, you need to know the MEDCOR criteria. You need to know when we escalate. You need to talk all of those through. Studying the emergencies, I've actually posted in the Telegram group the emergency manual for Queensland Health. It is really good resource. You need to study. I studied every single page of that book, the previous version. So study that. Oh, I have lost this slide. Okay, so let me just quickly explain the one question someone asked. What is that? What was the case? I said I will answer. I can't remember the question. Rajni, do you remember what was the question that I said I would answer in a short while?
It is being assessed or not, that one? The pilot station?
Pilot stations are not assessed, so you can't remark. And also, why remarking? Sorry, I had the score sheet earlier. I must have removed it. So when we work as an examiner, our grading is always tallied. So each domain, our grading, each examiner's grading is tallied across all stations to see whether we are a lenient marker or a horrible marker or a mean marker, whatever. You call whatever emotions you want to, but all of that is tested. And also the system has, so if I have marked multiple days, they have my criteria always. So they know where I am. So in the event of all of the 20 stations, it all evens out because every one of you will have a first station and a last station, and some lenient examiners, some nicer examiners, some mean examiners. So because examiners come in different forms and shapes, and so are the patients, that is real life. It is actually emulating the real life. And no examiner wakes up in the morning wanting to fail anyone. They don't. They don't do it. They're actually committed to their job. But sometimes when we see things that are wrong, we have to do our job and we have to fail that person so that they can be trained and they are not a threat to the patients. When you finish AMC 2, you are allowed to work in Australia under minimal supervision. So we need to be assured that, or not we, the examiners need to be assured that you are safe to work here. They're not being mean to you. They will not be. Anything else you guys need to know the answer? Okay, so I teach this 30 hours, one-to-one. That's what Rajni took. And then I have a book. You will see that in the Telegram after. And the book comes with the 500 OSCE phrases. And on an average, every candidate I coach gets 10 or more stations. Any questions that you need to remark? Don't ask for remark. Not worth. Yeah, don't ask for remark because it's not worth it. When I sign the iPad at the end of the day, when I finished marking, I sign it. That iPad will not get opened. The computer does the centralized marking and it does all the analysis and then it presents to the chief examiner. There is no moderation of marks. The only time the marking won't change. The only time something changes is that if one of the station had a problem, like you had to do a hearing test and the tuning fork didn't work, and often the AMC staff would have been flagged immediately, and they will ask you to stay back, and they will fix whatever went wrong, and they will ask you to do it again. But if it was not flagged, then that station sometimes will become the pilot. But other than that, there is no point remarking. It is sad that people who sit with a score of 8 out of 14 then ask for 4 or 5 stations remark, hoping that they will get that one station. You're wasting your money. You're not going to have a positive result. It is much easier to sit the exam than waste the money and ask for a remark. I have never seen anyone getting a positive outcome. I've heard in the groups that people have passed, but I have never seen anyone. Never. Anything else you guys need to know? Yep, there are about 72 physical examination stations. Anything else? All right, it was a delight to talk to you guys. Good luck with your exam. I believe in each and every one of you. You can do this. And go and give the exam. You're ready for the exam. Thank you, guys. See you again later at some time.